to look at that. So the very first thing I would like to mention is there is some data that suggests that MR can predict cancer upgrading while still allowing for that treatment definitive therapy that has curative intent. And one of the issues we have right now is illustrated by this particular case, in which you have a baseline tumor that's very small. In 6 years, there was a little bit of change, not much change. And for some reason, within 1 year, this tumor really grew and became very, very obvious. We are not yet sure why some patients behave like this, why some tumors behave like this, but we do know that in many cases, there is a wide window that we can follow this patient, identify minor changes, and send treated. So in this particular case was 6 years. Now, here are 2 studies, and the orange arrow points to my name. And then in the first one at the top, it reads, multiparametric MRI can exclude prostate cancer progression in patients on active surveillance. And then the bottom one reads, multiparametric MR alone is insufficient to detect grade reclassification in active surveillance. The other thing you notice is that the authors are different. And if you read these papers, now you will see that the one on the top used what is called the precise criteria. So prostate cancer radiological estimation of change in sequential evaluation. It's also a 1 through 5 scale. And the one on the bottom used pyrads version 2 to make these assessments. And when you look at the way these criteria are described, you can see that in the top in precise, you have resolution of the features, you have a reduction in the size or conspicuity of the features, you have stable, you have significant increase in size or conspicuity, and I put significant underline because it can be a somewhat subjective criteria, or you have definitive progression. While in pyrads, what you have is a statement of probabilities. Very low, highly likely, very high. Important to keep in mind that right now there is no standardized criteria to determine progression of multiparametric MR, and precise seems to be the best step towards that. Now, one of the things that I like to always mention is that the way that pyrads was created and described the probability of disease is actually wishful thinking. Because when you look at it, it doesn't really work like that. And I'll show you a little bit more about that later. Now, here's a study of the change on serial MRI that was done at UCSF, looking at pyrad scores. And then in this particular one, what was found was that some patients on MRI 1 had a pyrad score 1, 2, or 3, and later they had the pyrad score 4, 5 on that follow-up. And what that is actually equivalent to a precise category 4 and or potentially 5. Interesting, that study that was published from UCSF showed results that are different from this. This one actually shows that MR can, in some cases, indeed identify the progression on the follow-up MR. But the main point here is to say that as long as we look in the right way, we're looking at the 2 systems in a very consistent approach. Now, what do we have here then? So you have a less conspicuous finding, precise 2, or stable appearance, precise 3. And in that particular case, we can potentially postpone biopsy or offer MR targeted biopsy. Remember, there are features that are visible, they're less conspicuous or they're stable. And now if you postpone biopsy or if you do targeted biopsy, this time point will depend on, again, other risk factors. Or if you see that there's clear progression, which is precise 4 or 5, then an MR targeted biopsy would be the ideal approach. Now, why do I mention that pyrads is wishful thinking, in part because not all, so this is an example, not all pyrads 4 are the same. And the criteria to describe a pyrads 4 lesion vary depending on its location. But in a simple way, now we can see in the bottom, my arrow disappeared here, but we can see that on their bottom left, you can upgrade a lesion to a PIRADS score 4 when the diffusion is 3 based on the contrast enhancement, or you can give it a PIRADS score 4 if the diffusion is deemed to be 4 irrespective of the contrast enhancement. And when you look in the other table, you can see that there are two other approaches to actually give a PIRADS 4 score as well. And so when we look at these two cases here, the one with the bigger, thicker arrow was a PIRADS score 4, and I'm showing the T2 because it illustrates it better, but it was a 4 because the diffusion was a 4. And then on the one on the bottom, in which has the thin, long arrow, the image on the bottom of the T2 shows a very ill-defined abnormality on that peripheral zone, which was upgraded to a 4 because of the contrast, which is shown to its right side. These two lesions clearly are not the same thing. Now, the one on the top is clearly a more aggressive tumor in spite of receiving a same final PIRADS score. Now, again, here just to illustrate that we can do things to actually improve the characterization of risk. And what this graph basically shows is that when you have a PIRADS score 4 lesion and you have a PSA density that's 0.15 or higher, now the lesions behave as a PIRADS 5 lesion. So the risk of that patient is more similar to a PIRADS 5, or a patient that has a PIRADS 5 lesion than one that has a PIRADS 4. So we can use things that are very simple in conjunction with MR to better characterize risk. Now, let's go back here to transrectal ultrasound-guided biopsy. Now, it is well known that transrectal ultrasound-guided biopsy is associated with acute prostatitis, and that a lot of these cases are caused by microbes that are resistant to the more common antibiotics, requiring more aggressive treatments, more expensive treatments. It's known too that some patients will even require hospitalization because of that. Now, it's also well known that a transrectal ultrasound-guided biopsy is not one biopsy, but it's actually a lot of biopsies. And in general, the protocols use 12 to 16 cores, in some cases more, and that can be a problem. So the question then is, can we do fewer cores to actually characterize the disease just as well? If we decrease the number of cores, maybe we decrease the risk of infection, for example. So in other words, we can ask the same thing by using this question: do we need a systematic biopsy as well? Or can we do only an MR targeted biopsy? Before we read this slide here, I want to say that we don't know the answer for that yet. Now, most of the urologists that have experience with prostate cancer and have experience with transrectal ultrasound and have experience with MR will say, yes, we do need systematic biopsy. But I want to bring this study up and we'll read. So this is a study was very recently published. This also comes from UCSF. And the title of the study is Characteristics of Cancer Progression on Serial Biopsy in Men on Active Surveillance at Early Stage Prostate Cancer, Implications for Focal Therapy. And what they're doing, they're looking at can we look at these patients with biopsy and see if they can actually undergo focal therapy instead of surgery or radiation therapy. So this is taken from the study. Now, findings of serial biopsies in men with low or intermediate risk disease on active surveillance show that tumor location remains relatively stable over time, and that significant changes in grade or volume occur largely in the dominant tumor. Now, a note that I added here, dominant tumor is basically the tumor that's visible on MRI. Now continue to what was written. The combination of diagnostic and confirmatory biopsy findings better select patients for focal therapy than the use of diagnostic biopsy alone. Now this also comes from the paper. Multiparametric MRI results were utilized to confirm the dominant tumor location. So again, the dominant tumor is the one that's visible. Given that multiparametric MRI adoption is now widespread and most men have undergone multiparametric MR fusion biopsy diagnosis, it may be feasible to offer focal therapy based on this information alone. So what they're saying is, now if the MR shows the lesion, we know that the biopsy of that lesion really doesn't change, we can potentially just use focal therapy based on MRI. So if focal therapy is feasible on MR and fusion biopsy alone, MRI targeted biopsy alone is probably enough in active surveillance when the follow-up MRI is positive, right? Again, this study was not done to answer that specific question, but it definitely suggests that that is true, because if you're going to offer treatment based on that, why not offer the biopsy based on that, which is the step before treatment. And then the other time point where we're going to use MR in active surveillance is when the PSA is going up, and then prior to that biopsy, now we can do an MR, and if the MR is positive, then we do targeted biopsy to try to identify disease upgrade. Now, the $64,000 question, no one wants 64,000. Now everyone wants $1 million or more. Now, who wants to be a millionaire? I think not who wants to be own 64,000. Can MRI replace serial biopsies in men on active surveillance on for prostate cancer? And this is coming from Carolyn Moore, Mark Everton, who are urologists, not radiologists. And before we can do that, again, we have to answer a few questions. So what is clinically significant disease on MRI? What is progression of disease on MRI? And what is the significance of clinically significant prostate cancer diagnosed after a negative MR? I think for number 1 and 2, we can say that visibility, conspicuity, and size are the things that we use to identify clinically significant disease on MRI. Progression of MRI, perhaps the precise categories, maybe they'll have to be tweaked a little bit, but we're getting there. But the third question, we don't yet have an answer. What is the significance for that? Now, this sentence summarizes this. Though the impact of these non-visible lesions, which are presumably very small in volume, is unknown. We just don't know. Now, we need outcome studies to figure that out. That will be the missing part of the puzzle here. Once we have that, we may be able to be a little bit more comfortable saying, okay, let's just not do this biopsy. Let's postpone it for even longer than we currently do. And why do I say that we currently do? Because you all know we do it. We do postpone the biopsies based on imaging results. So there is light in the end of the tunnel. And I took this from a medical chart. This was in 2015. So it's been a little while already. And what it reads is that if MRI is normal, we might be able to follow him in the future, replacing biopsies with follow-up MRI. So if 5 years ago, one of the urologists was already talking about that, now they're definitely talking much more today. Now, they might not do this in every patient because it would not be appropriate to do it in every patient, but it's certainly something that's happening more and more often. Now here, I'm going to show you very briefly 4 studies that were done that actually brought MR even more to the center of the discussions. And I don't want to go into a lot of details, but basically what this says, all the 4 studies will talk about the MR pathway. And the MR pathway is do an MR before you do a biopsy rather than just doing systematic biopsy or adding a systematic biopsy. The smiley face on the top says that MR has a lot of beneficial features. This is the precision study that was published in the New England Journal of Medicine, and it basically states that if we do an MR, we do fewer biopsies when the MR is negative. We identify more of the Gleason 3+4 tumors than with the systematic alone. We identify fewer of the tumors we do not want to identify, which are the Gleason 3+3, and we can do that with fewer cores. This is another study. This is MRI first from a group in France, and it basically says the same thing, except that there was no difference in the number of Gleason score 3+4 or higher that were identified with the systematic biopsies versus the MR pathway. The other ones were the same. So fewer biopsies, fewer insignificant tumors, and fewer cores. Another study, this is the 4M, and similar findings to the other one, fewer biopsies, fewer insignificant tumors, fewer cores, and no difference in the Gleason 3+4 or higher. And then finally, this meta-analysis, which is basically a combination of multiple different studies using statistical methods to increase the number of patients that we have. And it again shows similar findings. If you use the MR pathway, you avoid biopsies, you detect fewer of the tumors that you do not want to identify. So in this case, they used the International Society of Urological Pathology. So the group 1, ISUP group 1, this is equivalent to Gleason 3+3. And then you detect more of those higher Gleason score or higher ISUP groups. So greater than 2 and greater than 3. So based on these studies, several different institutions and groups gave the thumbs up to MR, so NICE in the UK, NCCN, as we mentioned before, ASTRO, AUA, and others. So what I would like to do now is talk a little bit about pyrads, because I know this is something that is in the mind of a lot of people. People talk about pyrads all the time, and I get questions about pyrads all the time. What is pyrads? So pyrads is a way of making something that is understandable to one person, understandable to the other one. So this is pre-pyrads. We had this entanglement in the head of the other people while we thought it was something very neat. And the reason we had that is because we were using different scores, different magnets, different brands, different coils. Everyone was doing its own thing, so there was no consistency. And even before pyrads, the group of Dr. Dickinson and Mark Emberton, so Mark was the main person, Louise Dixon was the first author, already came with a recommendation to standardize the MRI. At the same time, or very soon after, we had the first pyrads publication, and then the version 2 by the ACR, and then the current version 2.1. And what is it? It's a method that has the goal to improve detection, localization, characterization, and risk stratification when patients have not yet had any treatment. So it's only applicable to treatment-naive prostate glands, and that happens to be potentially what we have in active surveillance. If you think about it a different way, is basically an ISO approach to standardize acquisition and quality of MRI. Now, how reliable that is. So again, let's go back to that levels of suspicion. We have 1 through 5, very low, low, intermediate, high, very high. And when you look at that, now you have this utopic idea that this is a linear scale tool. And it's not. Really, what happens, that's wishful thinking again, that's the little girl there. What really happens is that we have a much different distribution of results. And here are now the results of a meta-analysis that was done. And what we see in the table is the percentage of cases with Gleason 3, 3+4, 4+3, and 8 in those different categories. Category 1 and 2 are bundled together because both of those characterize a negative study. And then what we have on the far end, 6.4, 11.5, 48.2, 72.2, are the results for Gleason 3+4 or higher within each one of those categories. Now, the problem is that the data was very heterogeneous, and it was sometimes hard to figure out exactly what each one group was doing. Now, this is another study that has been published and looked at the positive predictive value, again, across 26 centers with a lot of experience. And now, again, we had similar results with wide variation and heterogeneity. So here in black and white are the results of the meta-analysis, and to its left are the results of this particular study. And you can see the numbers are very close, although the PYRADS 4 had fewer cases of clinically significant prostate cancer on this study, that not the meta-analysis, but the current one showing. On the side, we have the variation, the interquartile range. So 75% of the institutions. So if you look at PYRADS 3, 15%, 11.5%, and then the interquartile range is 10 to 26. That says that 75% of the patient, the institutions had that range. You could have gone from 10% to 26% probability of having high Gleason score. Now, why does that happen? It happens because PYRADS is not really an objective measure. It's actually quite subjective in many ways. And because it's subjective, readers do not read it the same way. And because they don't read it the same way, they don't assign the same scores necessarily in the different categories or in the different sequences. So there's better agreement in the peripheral zone, in the transition zone, but it's no perfect agreement. Now, this is from Anwar Padani. That now let me use those other slides about the 4 studies before and talking about the particular study, right? So positive predictive value, variability in MRI, directed biopsy. And the question he asked, is this the radiologist, is this the surgeon, is it the patient? And the reality is that it's probably a little bit of all of them. Now, we have to have adherence to technical standards. We have to have good MR imaging quality. The reader needs to be a good reader. We have to now determine what suspicion threshold was used for biopsy. So now if one center does not biopsy all PYRADS 3 scores and another one does, why? What is the difference? What is it that's triggering a biopsy in some cases but not all? Which method was used? How good is the person performing the biopsy? Was it fusion? Was it not? Is it urologist, the radiologist? And even in histology, there is variation. Histological assessments also vary. And all that needs to be taken into account, and we need to actually have a team working around these issues to improve risk assessment of that particular patient. So PYRADS is a work in progress for sure. It's not perfect, but it's good and it's getting better. And one of the main things that I want to highlight here is that multiparametric MRI is not PYRADS. PYRADS is one way of looking at multiparametric MRI. And multiparametric MRI is also evolving and might also change with time. Now, what was one of the good things about PYRADS is that it disseminated MR to many other radiologists that were afraid of doing prostate MR, increasing the availability of that test and access. But the reality is that it only increased access in the cities. Now, if you look at the rural population, we still have now ways to go, and it's still a quite expensive method. Now, very briefly, I want to talk about things that are coming in the pipe, and PSMA is one of them. What is PSMA imaging. It's a PET type of imaging. And the prostate-specific membrane antigen, PSMA, is basically a protein that exists and is overexpressed in prostate cancer. So we have many more of that protein in the prostate cancer cell compared to the normal cell. And when you take something that actually adheres to that and you tag it with something that becomes bright, what you have is that. Now you have the prostate cancer cell that shines while the normal cell doesn't shine as much, and therefore you can identify where the cancer is located. Usually we use gallium or indium or F18 fluoride to do that tagging. So here's an example of one patient, a 72-year-old gentleman with Gleason 4+4, and we can see on the left side the PET image, very dark area there. That's the big tumor. And this particular patient, the tumor is very obvious on the MR, so it's not really adding much there. Here's the same patient again, but what it did add was the identification of that little lymph node that is being pointed to in the bottom row. That lymph node might have not been identified as easily on MR, and it's very easy to see them with PSMA. This is another patient, status post prostatectomy. This is not active surveillance, and we can see tumors that are seen again on the humors of the patient. There's an area of uptake which is much more conspicuous on the PET, and then a lymph node that's very small and very clear on the PET, probably not visible but not recognizable as abnormal on the CT scan. And here's another case in which you have a negative CT scan, a negative bone scintigraphy, and a positive PSMA. So PSMA is actually quite a tool, and it's changing the way we see prostate cancer, for sure. Now we can look at PSMA, looking at serum PSA2, and you can see that 58% of the men, that this is the very first column in this graph, 58% of the men in this particular study had a positive PSMA, even though their serum PSA was between 0 and 0.2. This is men that underwent radical prostatectomy, by the way, not under active surveillance. Why does this matter? Because the threshold to trigger evaluation following radical prostatectomy is above 0.2. Now, there's not a lot of data on PSMA in active surveillance, but this is one study that was published. The problem here is that there's non-negligible overlap in the SUV. SUV is how bright the spots are. So when we see something that's very bright, now we know it's abnormal, we can measure how bright it is. And because now there's a lot of overlap, now it can be tricky to actually apply this in practice. And also there were these two outliers in the study that potentially made these results look a little bit better. Another issue is that there's no ISO grade group 1, which is the Gleason 3+3, which is what most people under active surveillance actually present with. Here there's another study that looked similarly at these patients, but what they did is they compiled group 1 and 2. Group 1 again is Gleason 3+3. And so that also can have an impact on the results, because when you separate the two, you see that there are only 10 patients with grade group 1, which is the grade group probably of most interested in active surveillance, but promising results. Now, more to come in the future for sure. Now, again, data is too scarce and preliminary. We cannot even use PSMA in the US. It's not approved. It will probably be approved very soon for patients with suspected recurrence following treatment, and it's definitely investigation on the setting of active surveillance. And then another thing is micro ultrasound, and the disclaimer here is I have zero experience. A friend of mine, Sanjit Gai, shared the slides with me. It's basically a new approach to ultrasound to use very high frequency Now, just to give you a sense, the normal frequency of regular ultrasound is about 6 to 9. In this case here, they're using 29 megahertz, which increases the spatial resolution down to 70 microns. And the way it's done, it's very similar to the regular ultrasound. So any urologist that knows how to do regular ultrasound can learn how to do this. They just need to get used to the images. Oops. Here we have the video, now scrolling through the images, and you can see those little dots, those little dark lines. This is all glands. I think a more important image is this one here that compares the same patient, the ultrasound and the MR, and you can see the red arrow, the more anterior lesion, and then the orange arrow, the more posterior one. Again, there's not a lot of data here, but this study here, which is probably the best study, looked at, compared the two modalities. The results of the test with micro ultrasound are based on this Primus assessment. So they looked at Primus 3, 4, or 5, and pyrads 3, 4, or 5 as a positive test, and the outcome was the grade group 2 on the biopsy. And what they found is that the ultrasound was more sensitive and as specific as MRI, meaning that it would see more things. And then the things that it saw were just as often as MR, high-grade disease. Now, it's promising, but there are also limitations. Again, the study is the best study, but it's not perfect because systematic biopsy was not always performed. The ultrasound was always done after the MRI, meaning that the person that did the ultrasound had access to the MR result and helped to identify the target. Biopsies of borderline lesions were performed or not. It's not clear why. And the biopsies were not always done with fusion. Several different approaches were done. But again, it's a promising technique that needs more data. And this is from their own study. There was substantial variation between sites. Now, here is just to illustrate the results. They looked at two different approaches. So the non-inferiority, which says, okay, it's not worse than MRI. And then they looked also at the comparison. So what's the value of it? It's to be determined. We don't yet know. In the end, what we really want to do is take care of the patient, and we should never forget that. And this is a slide I don't need to show you, but I show my trainees and the radiologists. We oftentimes are hiding behind a computer in a dark room, and we forget that there's a person behind that image. And I think it's very, very important to keep that in mind. What else we want? We want something that's simple, that's fast, that's reproducible, and that's accurate. That's the type of imaging that we want. And we work every day to get there, and why not get something that looks beautiful too, if it's possible. So to summarize, MRI of the prostate is not a perfect technique, but it's a marked improvement compared to what we had before MRI, and it is indeed an excellent addition to the active surveillance toolbox. Thank you very much.
Dr. Westphalen, thank you very much. That was a very thorough presentation, and hopefully everybody got a good bit out of it. Before we do get into the questions, I would like to apologize to the audience that there was a problem with Dr. Westphalen's camcorder, so we were unable to present his image. And I accidentally triggered the polls, which I guess some of you have seen, and we'll try to see if we can get you those results. With that, I will turn it over to Howard and team to start reviewing a lot of the questions that have come in. And again, there we go. That's not Howard, that's Elliott, but okay. There's Howard and Elliott.
Yeah, we're a tag team. So I'll start off. We've gotten questions live. We have questions emailed in, and we compiled questions of our own, and we'll draw from these different pools. We'll try to combine questions when we can. And I'm going to start off with a question having to do with guidelines that are recommended for men on active surveillance. So Dr. Westphalen, what do the guidelines recommend now in terms of MRI? Do they recommend specifically having an MRI before a biopsy?
So first, no one is missing anything by not seeing me, so don't worry about that part. Now, MR
we know
prior
you're
to,
shy. You're shy, that's why.
very shy, very shy. Not true, but that's okay. Sorry about that. I couldn't help myself. There are recommendations. So no, when you look at guidelines, recommendations, and statements, all those things have particular meanings. And guidelines are probably the most definitive ones and the ones that take longer to make changes. So with that in mind, I'm going to use the term guidelines for all those different things. There is a statement today, and this is accepted by virtually everyone, that if someone has suspected prostate cancer, had a transrectal ultrasound guided biopsy, PSA was negative, PSA continues to rise, they should get an MR to evaluate that. That's accepted by everyone. So that's the first one. Now, there are statements or those guidelines, I guess it was the word guidelines, that suggest that state that MR could be used for the confirmatory biopsy. So you have a known diagnosis, you will have a confirmatory biopsy done, and getting an MR prior to that is adequate and should be done. Not all state that, but some do. And it seems like that's the direction things are going. The problem is that the timing of all these guidelines is different. And people tend to be a little bit more, let's say, proactive making these changes, probably in Europe compared to here. They happen usually before there than here. Now, beyond that, there is no other recommendation. There's no statement saying that an MR should be done prior to the follow-up biopsy. That said, a lot of urologists do that. Does that answer the question?
Sure. Now, one of the people who submitted the question, and a couple of other people too have brought this up, and you kind of alluded to it in terms of Gleason 6. What is the future of Gleason 6? Will it be redefined as precancerous or non-cancerous? Do you have a dog in the fight? Does it matter?
I'll tell you this now, for everyone that's listening who asked the question, don't miss the next talk. That will be the person who know that answer, will have a definitive answer for that question. But that said,
yeah.
That said, and I read one that people are talking about benign tumor, right? So,
right.
Not all tumors are malignant. Tumor is a term that we use for a growth, let's say, and there are benign growths. So cancer, I guess the question is there a benign, quote, cancer? And many people say that Gleason 3+3 should actually be characterized as something else, not cancer. And that is why the International Society of Urological Pathology created the groups to try to separate that. Another reason too is because if there's 3+3, there was a 2+3, a 3+2, a 2+2. So Gleason score implied the idea that there would be something from 2 to 10, right? And then someone had the 6. And then the urologist said, oh, you have a 6, don't worry about it. And then he said, what do you mean don't worry about it? I'm above the half of that scale. that goes from 2 to 10, I'm a 6. I have to worry about it. No, don't worry about it, because 5 below don't exist. Those are not cancers. So why does that happen? And because of all that confusion, that's why those new groups were created. And they created group 1 to separate that. And I do think, and this is just my impression, I'm not the right person to ask, that it will eventually be considered to be a non-cancer, maybe, let's say, quote, quote, benign cancer, precancerous. But I don't know the answer for that. I am not the expert in that area.
Well, let me put in a plug for our next webinar, since you alluded to it. On December 30th, we're having our 4th and final webinar in the series with Dr. Jonathan Epstein, who's sort of the guru of Gleason's, and he can address what you discussed. But I was talking today to Dr. Peter Carroll on other matters, and I asked him, and he, for one, says let's leave it alone. He says we as a society and we as men with cancer need to get over the fact that there is such a thing as cancer, and there always will be such a thing as cancer. And tomorrow I'm talking to somebody who has a career goal of eliminating the Gleason 6 as a cancer. So it sounds like we have some interesting things to argue about. But Elliott, do you want to dive in?
I do. So Dr. Westphalen, so sort of piggybacking on that, looking at those of us who have grade 2, like low intermediate risk, or favorable intermediate is what I would say. 3+4, but we're on AS. So do you think that the protocols should be different, and are the procedures any different? Is the MRI any different? Is for grade 2?
I would say no. I think now there are already too many differences. There are too many criteria. We already have too many differences. I think we should keep things as consistent as possible. So if we were to create different protocols to different Gleason scores, officially at least, then that will be very difficult. Now, that said, now everything we do is in fact tailored to the patient. As I said before, when I read a case, and because there is some subjectivity to it, and I see something that I'm debating, should I call it a 3 or a 4? Now, a purist will say, well, don't look at anything else. You're a radiologist. You look only at the image, and you have to make a decision. That's not real life. And that's why I bring the pictures of all those men. Now, what I do is I open the chart, I look at the PSA, I look at the history, I look at what other results. Is there a 4K? Is that a GPS score? What was the Gleason? And then I make my call. So we shouldn't really do a guideline, official guideline that separates those things, but in real life we do it. Now, each patient is different, and we tailor the way we do things to that one individual. So now I probably would not change anything. And imaging wise, if we talk about MR only, disconsider everything else, maybe the one thing that we could do is to actually have a simplified protocol to follow up. So once I know there's something visible or not, my next exam could potentially be simpler, be a bioparametric MR rather than a full multiparametric MR with contrast. That's a possibility. But again, it would be probably tailored on other things too, based on other things.
Would that shorten the time? Because that's one of the things that I get asked a lot is that the fact that an MR is maybe 40 or 45 minutes, and is that something in the cards of shortening that time span?
Correct. That would cut part of the study. And the other thing people talk, so remember, now you do multiparametric MR. I just showed you axial images, but the reality is that I do an axial, I do a coronal, I do a sagittal, of the T2s, and then I do a diffusion on the axial plane and the sagittal plane, and then I do the contrast enhancement. So it's multiple sequences really. On a bioparametric, what we could potentially do, again, once we know what the baseline is, right? Not before. Then I could potentially just do an axial plane of the T2 and an axial plane of the diffusion. So it would significantly shorten the time of the scan.
Thank you.
One of the questions, if I can jump in here a second, that keeps coming up also is on the topic of contrast, and gadolinium seems to be everyone's favorite to discuss. And you know, doctor, if you could just maybe allude to the fact that there are several different types of contrast that can be used, and certain
Correct.
times when it might be more important than others to use them as compared to bypassing.
Correct. That was how I met Howard, I believe. We
Right.
talked about contrast a few years ago. So yeah, the first part, there are several different types of contrast. So the contrast we use for MRI is gadolinium, and there are different molecular structures of gadolinium, and some of those are more unstable in the body, others are more stable in the body, and the unstable ones are really not used anymore. All the data that, not all the data, but no, the vast majority of the data that we have on deposits and on nephrogenic systemic fibrosis of GAD is old data that was based on these older, more unstable forms of gadolinium. The newer ones have very, very little shown as cause of nephrogenic systemic fibrosis, actually none. And then the deposits, they're still found, they're still associated with even the newer ones, but we don't really know what those deposits mean. So that's the first part. The gadolinium that we use is not the same gadolinium that used to be administered to the patients. Now, when do we use gadolinium? I know there's a lot of debate about that in our societies as well. Some people really do not want to use gadolinium at all, while other people's are strong proponents of it. And I tend to be, we say in Brazil, neither 8 or 80 nor 80. Now it's somewhere in between. And there are situations where I think we should do. First, it can be helpful to identify lesions that are subtle on the other sequences. And we never know when that will happen. And because we never know when it will happen, the alternative is to give it to everyone at least at one time point. So at the baseline for active surveillance, I think it's appropriate. Once we know what's there, then we can avoid it. So the follow-up could be a bioparametric. Another situation where it's crucial to use it is following treatment. So after radiation therapy and after radical prostatectomy, a little bit less, but also after radical prostatectomy, gadolinium is very good. It's really helpful and it should be used. People should not be afraid of that. Now, it's also important to remember that the risk of gadolinium, there were two things in the media that actually led to this discussion. One was nephrogenic systemic fibrosis, which is a very debilitating process, which doesn't happen anymore. So that's a non-issue anymore. The other one were the deposits that were seen in the brain and bones and other organs. That is still happens. It happens less than before, but it still happens. But we don't know what that causes. There hasn't been any clinical implication shown because of these deposits. So this is one side of the equation. If I get gadolinium, maybe I will have deposits. And if I have deposits, I don't know what will happen. The other side is I have a prostate cancer that I treated. I know I treated it. It was a Gleason 4+3 with radiation therapy. My PSA is going up. I need to treat this again. I need to know if there's tumor in the gland. So when you weigh the risks and the benefits of the tool, the benefits outweigh those risks by light years. And I think it's something that people should keep in mind. And we do all the time. We don't use gadolinium if we don't have to use, if we don't think there's a benefit to it.
Okay, Joe, can I jump in?
Please.
Okay, or may I, Mom?
No, I definitely, I had to get the question on GAD in there because that's comes up all the time, constantly all the time. And, you know, it's often done in reference by some folks who have had bad images of it from years beyond.
I see. So, Antonio, there's several questions relating to MRI and artificial hips. And I really hadn't thought about that, but I guess in our age group, a lot of us, not Elliott, he's still a boy, well, how common, do you have any idea how common hip replacements are in an active surveillance audience or population?
They're more common than I would want. I don't know the exact number, to be honest, but we do see it, and they do degrade the images, the quality of the images. Now, this is another scenario where contrast can be helpful. So the sequence that gets most of the artifact due to the presence of the hips is the diffusion. It's often not usable. Now, if we're lucky, we can use a little part of it, but very often we cannot use it at all. The second one that gets more artifact is the T2. And the one that gets the least amount of artifact is the contrast enhanced images. So that's another group of patients where the contrast can actually be helpful. There are techniques to minimize the artifact. Those techniques are usually used by the musculoskeletal radiologist. They haven't really been, and the reason is they need to look at the bone where the artifact is. People have tried to use it for the prostate MR, but with not a lot of success. And in general, when there is hip replacement, if it's bilateral, we will, if we know ahead of time, inform the patient that might not be a good idea to proceed with the MR. If it's unilateral and the tumor is on the other side, may actually work. But no, very often I'm surprised by seeing studies that are not really interpretable, which is unfortunate. Now, the other thing too that is increasing are other types of implants, like cardiac implants, for instance, pacemakers. And I dealt a lot with it at UCSF. I used to chair the MR safety committee there. And now here we're not doing as many. We used to do a lot of those at UCSF. And I think it's important for people to know that there are implants, pacemakers that are called conditional that can be scanned under certain conditions. And then there are pacemakers that are not conditional that we don't know if they can be or not. And we could in particular cases, but I used to tell Peter and the other urologists that if it's a non-conditional, it would probably be safer to proceed with ultrasound rather than MR. The conditional ones we would do. Now, a different type of scan or shorter scan, but we would do it.
You know, we have a couple of participants in the audience who do have bilateral hip issues, and they're wondering what alternatives they have if they can't have an MRI. You mentioned ultrasound, so
it's not that they cannot have an MR. They can. There's a good chance that it's not going to be useful. So those are two different things. So if they had one before, they happened to have one before and it looked okay, if we repeat that same protocol, it should be okay again. Now, if they had one, it was bad, then probably better to avoid it. What can we do instead? So, we have the micro ultrasound coming. Maybe that is an alternative. I don't have experience with that, to be honest, but that's potentially one option. There are very initial studies. People are collecting data on PSMA and now maybe you can argue for Axamin too, so fluciclovine, so PET imaging to look at disease in the gland. There's not a lot of data yet, but we can see the tumor in the gland as well. We just don't know exactly what it means, which one is a bad one, which one is not. Can we say this tumor that I see at the baseline with the PSMA in the gland and the one that I see in the follow-up is different? We don't have that data yet, but that's potentially another thing that will happen. And then the old transrectal ultrasound guided biopsy still works and is still being done all over the world.
Yeah, let me ask you something that you had a little bit more about what you had mentioned earlier. I know your own research has shown that that apparently radiologists have varying skills at reading these MRIs, and not all. There's radiologists, and some specialize in abdominal, and some don't, and some are general. And so maybe two things here. As patients, how can we find the best expertise, to look, to get these MRIs from, the best centers? I mean, is it worth it to travel to a center if we can afford it?
Yeah, you brought up what I was going to bring too. So now ideally you want to see someone who has done many of these. What is many? There's a magic number being thrown out there, which is about 300, 400 MRs. Those are magic numbers. I usually tell my trainees they're voodoo. Someone came up with that. Obviously, the more you do, the better, right? So if you go to a community center and someone who is a generalist is doing neuro cases, MSK cases, and does a prostate once a month, that's probably not the ideal place. Now, if you go to a place where there is a team structure where urologists, radiologists, radiation oncologists, pathologists work together, you're probably in a good place. Even if it's not one of the places that has done the very first studies, they probably have enough experience to take care of you. I'll give an example. Now, very often a colleague of mine will read an MR of prostate. Maybe it's someone who hasn't as much experience as I have. And then when I talk to the urologist, we go to our tumor board meetings, they'll actually approach me and say, can you take a look? And I end up reading that case, even if I'm not really, if my name is not showing anywhere, right? So they're basing a lot of that on these multidisciplinary conferences and tumor boards. So now that would be the optimal scenario. And then there is the in-between, because not everyone can get to travel to a place or is in a place where you have. That's why I showed that slide of the rural US with a number of radiologists there. What can you do then? There are a few alternatives. One of them is to acquire. So there's a very nice initiative in, I think it's Michigan. And what they did there is they approached the university and small practices approached the university and said, well, we're not the university, but we're going to do the right thing. And they then said, this is our protocol. What do you think of it? And then the people that have been done more, so Matt Davenport was one of them, saying, okay, you should probably adjust this way or that way. And then they would go back and repeat. So they had that exchange with private practices. And there are similar things that happen in many other places. So if you are in a place where you don't have access to that institution with a multidisciplinary team, it's probably worth asking the clinic or the group that you will go if they have that relationship with anyone. And you'll be surprised that very often they do. People do have that exchange with us, and we try to help in one way or another. And now every once in a while they will reach out and, do you mind taking a look at this case for me? What do you think? And I think it's a matter of asking and trying to at least get to one of those places, because at least we know that the images will be acquired in the right way, and then if they have questions, if they feel they're not sure about what they're looking at, they'll reach out to someone to ask for an opinion. And then finally, another alternative is just ask for a second read, which there are alternatives for that as well. People have acquired studies at one center and then submitted to third-party groups to actually get a second read. Usually those groups will try to find experts in the area for different types of studies, not only prostate.
Okay, you were talking about the future, and we have one question about how long will it be before we have technology that can identify Gleason scores just from an MRI?
Huh. From an MR, I'm not sure we'll ever have. To identify, you mean to identify the anatomy itself? I don't know. I don't know what the question really means. We can predict things based on other features, right? So we see something that's very dark, we know that Gleason's higher. To identify
I guess the real
go ahead.
Yeah, I think the real point is there going to be some way to identify a Gleason score without an intervention, such as a biopsy?
I am an optimist, so I say yes, eventually. Probably will not be really Gleason score. We talked about that before, right? Gleason score is just one way of trying to identify behavior of tumor. And molecular imaging is the way that's going to, the direction we're going is into molecular imaging. And what I think will happen is that we'll have a different modality, maybe will be a PET modality, in which we'll have some sort of feature that will actually tell us, maybe genetics, for instance. We can link things to identify the genetics of tumors and then say, okay, this is a tumor that has this type of mutation or this type of abnormality, therefore this is a bad tumor. Call it Gleason, call it group, call it pirate, call it whatever you want, but it's bad. I think, and I'm not exactly sure what that will be yet, but that's where I see things going. Now, Gleason is just one way. It's the way pathologists do it.
One of the questions we got also from the audience was the question of is there research into strengthening? I think it's 3T is the standard now for the scan, but is there research going on to make it stronger, like to have stronger magnets? Is that possible?
Yeah, no, we have 7 Ts, and they are available now. We have at Washington, UC has them too. The issue with those, so one of them is that it's really hard to actually image a prostate because there is no coil. There's no surface coil. The coil is the bore itself. It's the scanner itself. That's the coil. So it's easy to do a brain or a wrist, for instance, or a knee, but it's hard to fit someone in there. The other thing too is that now for those, and for those who have done a 3T, now you probably remember how hot you felt and how many times you twitched and your eyes are blinking and your fingers are moving. Now you get into a 7T, that becomes even more. And then the artifacts related to the hips are more, artifacts related to air is more. You cannot do any type of implant like pacemakers. So I'm not sure that the strength of the magnet is where the hardware changes are going. I think there are other things that are happening. So one of them is faster and stronger gradients, which is how fast they can change the direction of the magnetization and how much they can change of that. That's one way people are going. The different vendors are working on better coils. They are working on different techniques, which is not hardware, but software techniques. So you can read signal from the coil in different ways. So you improve the quality of the image and decrease motion and increase resolution. A lot of the vendors are already incorporating artificial intelligence to these same models. So I think that's the direction that equipment, hardware / software will go rather than magnet strength.
Mm-hmm. Thank you.
Let's see, somebody else here was asking about some of these different agents, and I'm not sure, how they fit in. They're asking about fluorine and iridium.
Mm-hmm. Yeah, so radium is used for treat bone metastasis. People have been using it for a while, and this is the concept of theranostics, where you combine treatment and diagnosis. And this is definitely another direction that we're going to. So you can imagine, let's use PSMA as an example. You use PSMA, and then you can identify a lymph node that is positive, for example, or a bone mat. You identify a site of disease. And you can see it because you're using gallium, right? Gallium will radiate, and then you can capture that radiation. Now you can do the same thing. Instead of using gallium, you can use another agent that can also be visible, but at the same time will emit radiation very short distances, or very, very short distances, to treat that same finding. So now you give something that not only allows you to see it, but also radiates that locally. So that's theranostics. People are doing that, and also trials with widespread metastatic disease with quite impressive results. Again, not yet approved, but very, very promising. And then the idea is that because you can see, you can probably monitor the disease response to the treatment response.
I have another question here from that was emailed in, and it's: some men use color Doppler ultrasounds as part of their active surveillance, along with mpMRIs. And what is your opinion of color Doppler, especially in the hands of experts? And do you think there's a value in comparing the results of color Doppler to a recent or follow-up MRI?
So color Doppler is one of the components, is one of the things we can use when we do an ultrasound. And what it does, it basically detects the direction of flow of vessels. So things that go away from the transducer or towards the transducer will have a different frequency. It's like the siren of the fire truck going away or coming towards you. The frequency changes and you hear more acutely or not. That's the same concept. So it's done virtually always when people do a transrectal ultrasound guided biopsy. The idea is that if you identify an area that has more vascularity, that is a more suspicious area. And some of the urologists like it a lot, some like it a little bit less. I don't think it can be used to characterize disease. It can be used to identify suspicious areas rather than characterize disease.
Here's another.
Howard, I think we're running the doctor just a bit over time. So
I'm all right. Don't worry about it. I have fun here. So.
By the way, Joe, do you have the results on the polls?
I'm afraid to touch the button right now.
Okay.
So I'll check it, but it did some magic for me before.
So here's another question then from the audience. The question is that an MRI indicated that this person had multiple BPH nodules. What is that? And how do I know that it's non-cancerous or cancerous? And it
All
had
right.
a pyrad 2.
So BPH stands for benign prostatic hyperplasia, and it's a normal process of aging. In men that have prostate cancer, because of their age, most of them are 50 or more, all have BPH nodules, virtually all. And it's an expected finding. It's not cancer, and it's classified as a pyrads 2. That said, BPH nodules can mimic cancer. And I think one of the main limitations of MR is exactly in the transition zone where BPH happens. So BPH is common and is expected, and it's benign. In a few patients, it can mimic tumor. Tumor can look like BPH nodule, but that's uncommon. It's not the most common finding.
Okay, we have a quick poll result in here to election headquarters. Are you concerned about the use of gadolinium contrast with an MRI? And doctor, you don't have to answer that. This is the audience.
I cannot answer, but I can see the result.
Yeah, well, the thing is we have people who call in and they can't, so it's on their behalf that I'm reading it. And like everything else in America, there's a 52% to 48% split, with 52% being concerned about gadolinium. So, that doesn't give us an answer. But
yeah, again, I think gadolinium should be used when it's needed, and I do know why the concerns exist, and it's a matter of weighing risk and benefit, and it's very difficult to work with probabilities if you don't work with probabilities all the time. We all do it. We don't think about it. We all do it. Now, when we cross the street, we assess the probability that a truck will run over us. But we do it in medicine all the time, actually looking at numbers. So again, if you have a fair discussion with your referring urologist, and feel free to reach out to the radiologist anytime. We like when people reach out to us. And if you address concerns, then go for it. I've done MRs myself in which I use gadolinium.
That was a question that a number of people asked, which was, should we be reaching out to our radiologist to discuss the results of MR?
I would say reach out at any time, even before you have the scan. Now, one of the main issues is that in general, there is no structured way to do it. Now, we don't have a clinic, for instance, where you can come in and talk to us. Now, some places have thought about it. Stanford, I know, is one of the places that actually did a reasonably good job with a consulting system. But yeah, I would. I recommend reaching out, and now I have no issues at all with that. Anyone reach out to me, I try to help in one way or another. I may not be able to do it quickly, or I may not be able to do it to the extent that I would like to. But I think most people will be surprised that many, if not most, radiologists are actually very open to it.
And is one of the things that you mentioned in the slides was the precise scoring system. Would it make sense for those of us on active surveillance, we're going back for this, let's say, an MRI every year. Would it make more sense for us to be asking our radiologists for that score rather than just a pyrads score?
Yeah, I was afraid someone was going to ask that, but I had to add it there. So, it's a fairly recent thing. It comes from England, from Carolyn's group, Carolyn Moore's group. And I do think we do it subjectively. We actually do that without putting a number there. At least those that actually read quite a bit of those and have the comparison, because that's another issue. Sometimes we don't have the comparison. But when we do, we actually do that without assigning a precise score. So the report might read something larger, still pyrads 4, but larger, for example. I would like to have something, if not precise, something that's close to it, but I would like to see a little bit more data before, and it's yet not disseminated. I suspect it will become more disseminated soon. If you reach out to your radiologist, can you please add the precise score? They'll have no idea they're talking about unless there's someone that's actually actively reading and participating in these areas. So if you're in a multidisciplinary team, then yeah, they probably know. But if you're in a clinic, you go to Kaiser, for instance, they may not know about it.
Okay, thank you.
Well, I'll tell you what, I think it's about time to wrap. We weren't able to get to all of the questions, and we try not to get too personal with these questions, but maybe you'd come back and chat with us. And so, you know, I want to thank you for coming. You've earned yourself a sweatshirt, which is on its way.
They can see you wearing it. It's good.
Yeah, I wore mine today just to model it. So I want to thank you for coming. I want to remind people in the audience that we're going to have our regular meeting at 8 p.m. Eastern on Wednesday, and we're having Dr. Judd Moule from Duke University. And some of you were wanting to ask specific questions about yourself. You might stop by on Wednesday and ask Dr. Moule what he thinks. But at this point, thanks again, and I will turn this over to Jim.
On behalf of us too, Dr. Westphalen, I want to thank you for an excellent presentation. I'd also like to thank our other co-sponsors of this event, and certainly big thanks to AnCan, both for putting the program together, but for production and everything else they do. I think one of the messages that came through loud and clear to me this evening is there is new stuff out there, and to really get the benefit of that stuff, we need a multidisciplinary approach. And I think that has to happen when the patient walks in the door. So I think as a goal of us too, I think it's about educating patients about the benefit of that, and trying to make sure that every patient has that opportunity. Thank you.
Definitely.
So now I guess Peter gets the last word. Peter, you're probably muted.
Try now.
Me?
Peter.
Oh, Peter Kafka. Okay.
Okay, so on behalf of AnCan, I'd like to thank you, Dr. Westphalen, and all the others who participated in this. Rick mentioned a little bit about our organization. Probably many of you are familiar with it. We started out with a focus on prostate cancer. We've expanded beyond that, even beyond some cancers now, but we still have a primary focus on prostate cancer. We run some 12 individual groups a month dealing with prostate cancer specifically, and we've divided them up. We have groups that zero in on active surveillance, ones that zero in on low and intermediate, ones that zero in weekly on advanced disease, so that we can address people's concerns where they lie. And one of the great things about our organization, which Dr. Westphalen kind of pointed out in terms of accessibility to multiparametric MRIs, is that there are vast parts of the country where it isn't available. Well, our meetings are available to anyone. And you don't even need a computer. You can actually link in on phone. So there are about 180,000 gentlemen diagnosed every year with prostate cancer. Well, anyone can tune in real time to our meetings. They're drop in, there's no registration required, no fee, and we'd love to have you. We prioritize the time for new members, or I don't want to use the word members, but new people coming into the meeting who have concerns and questions. And we're not doctors, we don't give medical advice, but we put our collective hats, thinking caps on, and our hearts, and help each other. our motto is be your own best advocate. So our focus is on educating people, helping people find the best places to get second opinions, to get treatments, to ask the right questions, to formulate their questions for their doctors, and just generally take responsibility for their disease as best they can. So that's our primary goal in AnCan, and we invite and welcome any man or their partners or caregivers to join us. Thank you.
So before you close, I just want to thank you all again for the opportunity. I apologize for my camera snafu here. I'll try to figure out what happened for next time. And if anyone want to reach out, feel free, please send me an email or we can set another chat. Happy to do it. Thank you very much.
Thank you.
Look forward to talking to you more. Thank you. Very good evening.